All right. So this, and just so I can be clear, can somebody like maybe Spence, if you could just wave your hand if you can hear me and see the screen. Perfect. Thank you. So in preparing this monstrously large talk from this broad headline, I thought about the nature of today's audience, which is going to be fairly broad in expertise and orientation. Is going to be mostly not prescribing clinicians. All of you are working with people that are affected by psychotic illness. After all, this is the first episode, Psychosis, Echo. And you all are at the front lines of patient care, where you are undoubtedly going to be hearing, even though you're not prescribers, you're going to be hearing the hopes, the fears, the concerns, the everything around medication from your clients or their families. And it's I figured, therefore, I would try to shape this talk in ways that I imagine might be helpful for you in that scenario. One, I'm going to talk for a while about attitudes. Attitudes around medication are extremely important. We know that a person's attitude about their medication, in other words, a patient or client's attitude about their medication, strongly determines whether they're going to take that medication or not, or whether they would endure a side effect or abandon it. And client attitudes are oftentimes influenced or determined by family attitudes. And family attitudes or client attitudes are actually, we clinicians have substantial impact on attitudes of the consumers as well. So just to illustrate this, I'll tell you about a thing I do in many public lectures. In this, I would say you don't have to do this unless you feel like it, but you can simply send an email to me, type yes, and I will sign you up for a shot of Invega Sustenna, or the antipsychotic of your choice. So if anybody wants to try out what an antipsychotic medication is like, feel free to let me know. And from past experience, I would wager that maybe about 1 in 50 people will take me up on that offer. And the fact that most people are thinking, is he crazy? Why would I take this medicine? Is what I want you to think about. Because if you are fearful of trying this medicine, or do this, would you like Dr. Messamore to send you a sample of Abilify to take and try out? Or how about penicillin? Or how about Ativan? So, you'll have different reactions to different suggestions. And those reactions that you have, those are part of your, if you will, your transference, your subconscious attitudes, your fears or beliefs around medications, and you can't help but transmit these things to your clients. So if you are thinking that you wouldn't take these medicines, not that I say you have to, but I mean, if your attitude is one of fear and shock, that Messamore would suggest that you try it, that's interesting. And so I'd like you to think about what that might mean when you're trying to persuade your client or the family that they ought to take this medicine indefinitely. Common attitudes as well, reflecting decades of poorer practice, that we will use long-acting medications as a way to control people or to force people to take medicines. So in other words, those are the things that we would historically reserve for the so-called bad patients. There is, I think, largely due to the effectiveness of pharmaceutical company positioning of medicines, there is widespread hatred and fear about first-generation drugs like Haldol or Thorazine or Prolixin or Trilofan. They're actually just different sets of side effects, and I would argue that gaining 50 pounds is maybe not as, maybe equally bad as having a movement disorder or an EPS. So I'm just pointing out that the medicines, these are common attitudes which can get in the way of our talking with clients about them. And also, I think, reflecting largely trends in pharmaceutical marketing. For some 20 or more years, we've been moving way away from clozapine, and there's not really been any advocates to point out the benefits of clozapine, and there's been no shortage of reasons to be fearful of that medicine. So a common attitude is that this is a dangerous medicine that's reserved for the worst cases or as a last resort. And again, I just ask you to, survey yourself for what you might less than fully consciously feel around these medications, and be mindful of that when communicating with clients about them. Medications, and I'm going to shift a little bit from personal or clinician attitude toward medication to, if you will, societal attitudes about medication. There's been this remarkable shift in how we perceive the treatment of choice for psychiatric disorders in the 1930s, 40s, 50s, and 60s, even up through the 1970s. Psychodynamic psychotherapy was seen as the treatment of choice for almost all psychiatric illnesses, including the schizophrenias. Now hardly anybody gives the level of attention that psychotherapy used to get when talking about schizophrenia. We've shifted the pendulum to it's almost all time everywhere a medical disease that requires medication treatment. And indeed, medications are important because data are pretty abundant that people with medication tend to stay out of the hospital, tend to have better levels of functioning than people without medication. And continuing an effective medication will absolutely keep a person out of the hospital and absolutely help a person to achieve their goals. So yeah, lots. So these observations around antipsychotics really fall in line with societal attitudes about the way we treat mental illness these days. But medication is really not the end all be all. It's just one piece of a puzzle. This is an article from The Onion. I'll send out a PDF of these slides and you can read this humorous thing. But Prozac is complaining that it's supposed to fix this mess all on its own, reverse decades of hopelessness without the assistance of mature coping skills or supportive loved ones. And this is, I point this out because this is, in my consultation work, a lot of cases that I get seem to overlook the importance of environmental, social, psychological, relationship, purpose, and meaning sorts of things. And when clients are struggling, a lot of systems of care will try to answer that problem with a medication solution. But this is a kind of a crazy time that we live in. I hope the pendulum will swing a little bit more toward the proper mix of environment, social support, purpose and meaning, as well as pharmacology. So just comments about that. So what do medications do actually? So medications do only this. They bind to particular proteins in the body. We live because of the proteins that are in our cells. Proteins are like little machines that do the work of they're like, yeah, tiny machines that do the work of cellular life. And every drug will bind relatively specifically to one or two or three proteins. All proteins everywhere in their body are in a constant state of motion. They're actually wiggling. And when a drug binds to a specific protein, it changes the oscillation. It changes the frequency of it shifting between one shape and another shape. And that is exactly all that medicines do, except for general anesthetics or alcohol. But we can talk that in the level 200 course. And when the protein is bound to a medicine, it then changes its function to either make the protein better at the job it was designed to do or less efficient at the job it was designed to do. Occasionally, it can inactivate the protein as well. So medicines augment or inhibit existing functions in the body. They don't create new things and they don't really destroy new things. They can temporarily inactivate, but they don't necessarily entirely take it away. So think of this as changing the voltage within a wiring system rather than changing the wiring system itself. So you can put more juice through the system or you can take it away, but you can't like add more lights in the circuit unless you actually build the circuitry. So that on the very basic biochemical level is what they do. As I said, they inhibit or augment existing signals. They don't fundamentally change anything. They just enhance or inhibit what already is there. And as frontline clinicians, I think it's important. I hear this message a lot from clients, like, I'll be somebody different or this is going to change me. And I point out what medications do. They don't actually create or destroy things. They just augment existing things. So rather than changing you into a different person, dear client. We're actually offering the possibility of normalizing some signals to allow the real you, or the best version of yourself, to be more easily seen. In other words, they by taking away the overriding layer of paranoia, or by reducing the frequency and severity of distracting hallucinations, or in the case of antidepressants, by normalizing the body's hormonal responses to stress, then a person becomes less physiologically overwhelmed, and they can better tap into their thinking and their problem solving, and they set the conditions in which real healing can occur. Again, we can change the voltage a bit, which can be helpful if there's no light in the house. But if you want to have a really well lit house, you have to work on changing the wiring. And by giving a medication to sort of bring up the level of light a little bit, then you can more easily do the work of constructing the circuits that you need. And constructing circuits in the brain is exactly what happens when we engage in psychotherapy, when we engage in cognitive enhancement therapy, when we engage in problem solving in our life, when we change the relationship, when we change our behaviors within relationships. All these things ultimately translate into building circuits within the brain that serve healthier behaviors or healthier functions. So I think that it's a really fair analogy to say that medications are a lot like bicycles. They make it easier to go from ill to well, and they make one's efforts in that process a lot more efficient, but they rarely do it all by themselves. We tend, I think, all to get sucked into the idea that medication can be fundamentally transformative, because there is that one case out of 50 in which just a few milligrams of Abilify has resulted in the restoration of a person. But these cases are relatively rare. They stick out in our minds for their drama. And I think it's really important to remember that for most people, you will have, the medication will move them part of the way there, but in general, it makes their psychotherapy easier and more effective. Yeah, and the other thing about medicines, and why as a scientist I love drugs, is because medicines tell the truth. Medicines actually, I call them touchstones to physiological reality. And in psychiatry, this is especially valuable because in psychiatry, where everything is organized around mood, hallucination, behavioral, very broad and very fuzzy concepts. But a drug pays no attention to that. A drug just goes in the body and finds the protein that is the target. And so when you have a drug with known pharmacological properties and you give that drug to a symptomatic person and that person's symptoms get better, then you've actually learned a lot about what goes on with that illness. So if I give penicillin, if I know that penicillin kills a certain species of bacteria, and I give penicillin to somebody with pneumonia and that pneumonia resolves, I can be confident that that pneumonia was caused by that species of bacteria. Similarly, if I give a dopamine receptor blocking drug to somebody with hallucinations, and that person's hallucinations decline, I can be fairly confident that in that case, those hallucinations were caused by something that is related to excess dopamine signaling at that receptor. And conversely, if I give a dopamine blocking drug to somebody with hallucinations and they still have hallucinations, then among the possibilities to explain that is that that person's hallucinations actually don't have anything to do with what that drug is targeting. So medications have actually been telling us for as long as we've had them. In the case of antipsychotic drugs, for about 60 years now, medications have been telling us that not all schizophrenias are the same. Most schizophrenias do respond to most antipsychotic drugs, and most antipsychotic drugs are dopamine receptor blockers. Therefore, most schizophrenias, we can call them dopamine psychoses. However, some percentage of people with schizophrenia, in first episode clinics, it may be 10%. In more longer-term patients, it may be 30% or more. But a portion of people with schizophrenia-like symptoms actually don't have anything to do with dopamine as a cause of their illness. So when we see the first antipsychotic medication not work, and then the second antipsychotic medication not work, then it's a good chance that we're looking at a dopamine irrelevant psychosis. And I just jumped ahead of myself, but this slide explains what I just said. If a drug that targets dopamine receptors is ineffective, there's a good chance that the illness that we were treating doesn't have anything to do with dopamine signaling. Why is this important? Because this so-called, what I call dopamine irrelevant schizophrenia is more traditionally called treatment-resistant schizophrenia. And treatment-resistant schizophrenia, it actually responds very well to clozapine. And coming back to the beginning with attitudes, clozapine has been fairly severely maligned ever since it went off patent protection in the mid-1990s. Every other drug says they're as good as clozapine, at least in the beginning, which was kind of a lie. And in the process of trying to establish the superiority of Zyprexa or risperidone or something, people say, and clozapine is so dirty, it's so hard, it's so dangerous, da 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 da. So that attitude is kind of pervasive, that clozapine is a dirty, dangerous drug. But actually, it is in the people that have not responded to more than 2 antipsychotic drugs, clozapine will be well tolerated and effective in over half of those individuals, whereas the 3rd antipsychotic drug will have literally a single-digit rate of success. And one of the reasons why people are afraid of clozapine is because it has blood draws. It's the only medication in schizophrenia treatment that has this requirement. So it leads everybody to think that the white cell count is a dangerous problem. So to be clear, white blood cells are necessary for fighting infections. Clozapine can decrease the white blood cell production. And in some cases, this can be very dangerous. And in some cases, people can die from an infection. However, many second-generation drugs do exactly the same thing with almost the same rate as clozapine does. None of those drugs have been targeted by the FDA for mandatory weekly blood testing. Second, keep in mind the probability that somebody will have just a numerical decrease in their white blood cell count is literally less than 1%. And if they maintain their white cell count within the first 6 months of treatment, that probability declines even further. And there's a massive difference between having a drop in white blood cell count and being at serious risk of an infection or a potentially fatal infection. So the actual risk of death from this is way low, like 1/10 to 1 or below of 0.1%. I mean, because we check this routinely, we catch these things early. So almost nobody has problems with super infections due to that. So that is some white blood cell perspective, which I want to give you because I want to talk about suicide for perspective. Suicide attempts in schizophrenia are very common. Some estimates say that half of people with schizophrenia will make an attempt on their life. It's pretty clear that about 1 in 10 people with schizophrenia will actually die from suicide. Meanwhile, clozapine is the only drug that is approved by the United States FDA to reduce suicidality. And clozapine in schizophrenia can reduce suicidality to population mean, or to the population average, as if one didn't have schizophrenia. So let's do some math. Risk of death from schizophrenia, risk of death from suicide in schizophrenia, 10%. Risk of a white cell decline, 1%. Risk of death, less than that. So, if we're fearful of clozapine because we might cause white cell problems, and because of that fear we don't recommend clozapine, then 100 people die from suicide for every one that will be saved by not recommending clozapine for protecting their white cell count. This is to, I guess, as I draw to concluding, if we do a good job at engaging our patients in best practice medications, if they're dosed correctly, and this graph assumes that things like adherence to medication and the absence of drug use are present. Then the blue area represents remission or response. So people getting better are represented by the blue, and the bigger the blue field, the more responders. On the x-axis, we have months of treatment. So it shows that in stage 1, with the first antipsychotic drug, you will capture between 50 to 70% of individuals. They'll get better. In first episode clinics, that actually figure is probably closer to 80% with just the first antipsychotic drug. If they don't get better, then you'll catch an additional set of them with a shift to a second antipsychotic drug. And by this time, you're up to week 7 or 8. And by that time, if they're either better or they're not, and if they're not, they should be offered clozapine. And then 60% of the remainder will get better. So by the end of a year of treatment, following this algorithm, one is predicting that at least 80% of individuals with schizophrenia will either have a meaningful reduction in the symptom severity or an outright remission of their symptoms. So some final words and maybe tips to help you in discussing medications with your clients. It can be helpful to rename schizophrenia into dopamine psychosis. Most schizophrenias are fairly called a dopamine psychosis, and I think that labeling it dopamine psychosis helps to set the stage for accepting of medications which can moderately attenuate the dopamine signal. So you have a dopamine psychosis, let's give you medicine to try to help normalize the dopamine signal and see if that works. It's also helpful to remind people that medications help to make other things more effective. So we would encourage them to continue to engage in work with families, in work with psychotherapies, in solving environmental stresses. And actually, I think it's a lost bullet point, the last bullet point. It's a lost point that there's a lot about schizophrenia course which is actually in the control of the affected person. So they can be in control of whether they use psychotogenic drugs or not. They can, to a large extent, be in control of the stressors that are present in their lives, and they and their families can work on that. And doing things like cognitive enhancement or cognitive remediation or cognitive behavioral therapies can greatly improve things as well. Doses that are required to maintain remission of symptoms are usually much lower than doses required to induce remission of symptoms, and letting people know that after a period of stability, it is their right that their medication doses should be reduced to find the lowest effective dose for them. It will help to build engagement and rapport. And I would encourage folks, everybody who's attending, if you don't have clinic policies in place, to consider such things. They will say that with new intakes, patients will be informed that the expectation is they'll be on lower, that they will engage in therapeutic trials of lower doses as symptoms improve. And it may be worthwhile to put systems in place to ensure that dose reduction opportunities are explored during the course of treatment. So by, say, 6 months of stability, then one can begin to have discussions of dose reduction. And if you do this, you'll find that 10% or 20% of individuals with schizophrenia actually can succeed with no more medication, and another 30% or so can get by with doses of medication that seem ridiculously low. So having that as a target for people at the beginning of treatment, as I said, may help to better engage them, and knowing that it may also incentivize them to engage in things like resiliency training or supported employment work or cognitive behavior therapy and so forth. So those are the slides that I have for you. And